Our next presenters are Dr. Erika Waters and Sienna Ruiz, who are going to talk to us about the diversity of asthma care beliefs and practices and share some findings from one of their projects. So just a brief introduction to Dr. Waters and to Sienna. Dr. Waters is a professor in the Division of Public Health Sciences, Department of Surgery at Washington University School of Medicine, also has training in public health in addition to a PhD in social psych, and focuses on public perceptions of health hazards and their impacts on medical decisions. And then Sienna is currently a public health research coordinator, also at Washington University School of Medicine, focusing on qualitative work on medical geography and social determinants of health. Very much in step with our summit theme for today of diversity in asthma management. So please give a warm welcome to Dr. Waters and to Sienna, who are going to get their slides up and start off their presentation. And then we'll have one more educational presentation before we transition into some work group updates and awards.
That's fantastic. Thank you so much for that wonderful introduction. Today, Sienna and I are going to share the presentation, and you'll find out why in just a moment. I am thrilled to be presenting here today. I learned about this summit for the first time just maybe 6 months ago or so, and it sounded exactly like the type of venue where kind of our group could learn a lot, and hopefully we could describe what we've been doing over the last several years, describe some of our new findings, and hopefully help others learn a little bit as much as we're learning today. So anyway, about 5 years ago, James Shepard, who's a professor in psychology at the University of Florida, we were awarded a grant from the National Institutes of Health. And the purpose of the grant was to understand the social, psychological, and healthcare system factors that shape how caregivers of children with asthma, came to understand their child's asthma and how they made decisions about managing their child's asthma. And when we're talking about caregivers today, we're talking about parents, legal guardians, but also potentially grandparents, basically anybody who have not engaged in the healthcare system as a professional, as a healthcare provider, but those people who are with children day to day as they manage asthma and as they live with asthma. Our ultimate goal with this study is to develop and implement an intervention that will help caregivers, their children, and healthcare teams keep children with asthma as healthy and happy as possible. And so today's presentation will discuss what we learned in the first 3 years of the project. And I've asked Ms. Ruiz to actually develop and present this presentation because she has been a central team member for this entire duration of the project. She obtained her bachelor's degree in medical anthropology in 2020 from Washington University. And without her hard work and critical insights, we really would not know as much as we do today. So with that, I'm going to turn it over to Sienna, and we will go ahead and get started.
Awesome. Hi, everyone. I'm Sienna. I'm a research coordinator with the Asthma Caregivers and Children Project. And yeah, today we'll be reporting on the findings primarily from the qualitative side of this project. And just let me know if my slides get kind of weird. Hopefully it'll be good. But yeah, for some background, childhood asthma affects over 5 million US children. However, asthma is more common among children who are Black and whose parents have limited incomes and limited formal education. And this difference in asthma rates is due to many factors that aren't really under the control of caregivers or children. For example, discriminatory housing practices result in racially segregated neighborhoods with more asthma triggers. And in addition, discriminatory or weak environmental laws can result in people in Black neighborhoods living closer to highways, resulting in larger exposure to air pollution, as well as living close to chemical plants, which results in toxins in the environment. And this means that Black families are more exposed to air pollution and toxins that harm children's lungs. And there are also fewer healthcare providers in Black neighborhoods than in white neighborhoods, which means that Black families have to travel farther to get healthcare. And we know that preventing asthma exacerbations is a crucial asthma care goal for children with asthma. And because asthma exacerbations can be life-threatening, our research has focused on how caregivers, children, and doctors and other healthcare providers understood and managed asthma to try to prevent exacerbations. Sorry about that. Slides are being slow today. But yeah, basically, as we know the demographic makeup of those who experience asthma is diverse, as primarily Black or Latinx children experience the disproportionate burden of asthma. However, what we must also recognize is that those who experience and treat asthma have a diversity in thoughts, beliefs, household contexts, social arrangements, management strategies, and conceptual models of asthma that shape how they address asthma and why there might be discrepancies between groups. Some questions that we'll address today are: how do caregivers think about their child's asthma? How do those thoughts and feelings influence how they manage asthma? How do children themselves experience and manage asthma in their everyday lives? And what challenges and opportunities do differences in opinions on asthma create? My apologies for the slow slides. I will just jump into the study location. We completed the research in Gainesville, Florida, and St. Louis, Missouri. Residents in both Gainesville and St. Louis experience racism, poverty, and environmental injustices, such that Black populations in North St. Louis and East Gainesville experience higher levels of poor housing conditions, stress, and environmental risks for asthma, like air pollution, healthcare facilities, and levels of stress and environmental risks. And these areas also have limited access to supermarkets, pharmacies, public transportation, and healthcare facilities. Between 2010 and 2015, rates of asthma-related emergency room visits were 8.5 times higher for Black residents than white residents in St. Louis. In Alachua County, where Gainesville is located, emergency department visits were 6 times higher for Black than white residents in 2018. And we recruited caregivers to participate in 60-minute interviews between December 2018 and May 2019. Caregivers could participate if they were age 18 years or older, cared for a child under the age of 18 years, and spoke English. And several months into the study, we discovered that few participants had low incomes or cared for a child with asthma. So we increased our recruitment efforts so that those voices could be heard too. And we asked caregivers questions about asthma treatment, about how their child experienced asthma, how they manage their child's asthma, and the effects of asthma on their everyday lives. And we also recruited healthcare providers through university and professional networks. We interviewed these providers by phone or in person for about an hour. Interviewers asked these healthcare providers what they thought were the main problems that caregivers, children, and families had with asthma. And to interview children, we used a child-centered approach, which means that we saw children as unique individuals who are able to meaningfully participate in their own asthma care and research. Because children's asthma is managed mainly in the home, we also used household visits. And our original goal was to visit 12 families in their homes, and we would visit them twice within a 3-month period. During these household visits, we used activities like drawing, photography, and interviews to learn about children's experiences with asthma. And household visits averaged around 1.5 hours in length. And then after the COVID-19 pandemic began, we moved the study online. And for the Zoom interviews, we delivered a goodie bag full of snacks, craft supplies, and play materials before each interview, along with a research iPad and portable Wi-Fi device. Online interviews with children averaged around 45 minutes each. And we interviewed 41 caregivers total. We had 25 in St. Louis and 16 in Gainesville. Most were women at 83%, Black at 80%, and or had low incomes at 78%. We interviewed 12 healthcare providers, 7 in St. Louis and 4 in Gainesville. And this included pediatricians, school nurses, pulmonologists, and an asthma coach, as well as an emergency room resident. And we did household visits and online interviews with 24 children total, so 10 in St. Louis and 14 in Gainesville. Most of the children were between ages of 6 and 16 and had mild to moderate well-controlled asthma. The majority of the children were Black and at 71% and boys at 58%. Now we would like to introduce the findings from the qualitative side of the study. And one of our most important findings was that 3 key groups, caregivers, children, and healthcare providers, all understood and treated asthma differently. So my apologies. Most doctors and other healthcare providers we interviewed thought of asthma care in terms of how well caregivers followed their medication plans or action plans. And some healthcare providers noted social and environmental situations that worsened asthma, but in most cases, they didn't focus on those situations. Whereas caregivers described asthma management practices that went beyond the medication and asthma plans. Caregivers appeared to develop their own practices, partly in response to the difficulties they faced accessing medical care. For example, caregivers reported monitoring for symptoms where they closely watched and listened to their child's asthma. They managed emotions as they calmed their child during an asthma attack and tried to tell breathlessness apart from emotions like panic. And they would also control the home environment by cleaning, managing the temperature, filtering or purifying air, and trying to control other smoking habits. And they would also try to control the child's activity by avoiding triggering asthma. And some caregivers actually encourage physical activities to build lung capacity. And they managed symptoms with quick relief or rescue medication. Some caregivers did this when their child was having breathing problems. However, other caregivers gave it every day, thinking that it would prevent asthma in the future. They also used home remedies such as hot sauce, teas, and other drinks, steam, and peppers. And children often had information about asthma that caregivers or providers didn't have, mostly about experiences of asthma at school or on sports teams. Nevertheless, children's asthma management practices shared some similarities with those of their caregivers. These similarities included managing emotions and limiting physical activity. However, unlike caregivers, few children described managing their environments. In general, caregivers seemed to focus more on preventing asthma symptoms than children did, and children focused more on managing their asthma symptoms. And so complicating the many different understandings of asthma was the fact that many of the children in our study had received insufficient medical treatment for their asthma. Doctors and other healthcare providers noted that the undertreated asthma occurred because families didn't always remember to give children their controller medication, they didn't understand the importance of controller medication, or they needed controller medication, but they didn't have a prescription for one. However, the issue was more complicated than caregivers being reluctant to administer medication. From our interviews with caregivers, doctors, and other healthcare providers, we found 3 types of disconnects that more thoroughly explain why children's asthma was undertreated. There were system disconnects that included difficulties with insurance, primary care shortages, gaps between emergency and primary care, urgent care replacing primary care, and healthcare deserts. This led to situations where caregivers had difficulty following up with primary care physicians, and they would take their child to urgent care and have difficulties following up with a primary physician if they had one. And for example, Nicholas, a pediatrician in St. Louis, saw the problem as lying within the structure of medicine, the corporatization of healthcare, the compartmentalization of care, and the inadequate training of residents. And resource disconnects included a lack of healthcare providers in disadvantaged areas and challenges to accessing primary care due to time and transportation constraints. Caregivers also experienced life disruptions due to other illnesses and issues, which limited their time and ability to care for asthma. For example, caregiver Tasha had to battle with her child Kaylee's asthma attacks for 6-month stretches between appointments. Tasha was continuing a treatment recommended by an ER doctor when Kaylee was a baby that appears to never have been reassessed. When Kaylee now has an exacerbation, she returns to emergency care. As Tasha worries about the trigger for the attack, the ER doctor, not knowing that Kaylee's asthma is so undertreated, suggests paint chips as a potential trigger. And this leads Tasha to pour all of her resources into repainting the house rather than seeking more medication or care. And there were also interpersonal disconnects, which included different views about asthma and asthma management between caregivers and providers, as well as caregiver mistrust in healthcare providers. These differences resulted in misunderstandings and underprescription of controller medication. For example, Monique, a caregiver in Gainesville who had epilepsy, anxiety, and migraines, who also cared for her mother and her brother who had suffered a stroke, described her life as a day-to-day situation in which she had to make sure we can pass this crisis so we can get to the next one, she said. And consequently, her child Zoe's asthma was rarely the most pressing concern. The family appeared to have little asthma-related contact with medical professionals, and the school nurse was the one who administered Zoe's medicine each day. And when we asked each group how they understood and treated asthma, we got a variety of answers. Here's a depiction of the various issues involved in asthma management that participants raised. And different understandings of asthma layered on top of different levels of access to care for families resulted in a lot of potential problems for asthma management between providers, caregivers, and children. As I'm sure you've encountered, families may prioritize acute symptoms over chronic treatment due to the no symptoms, no asthma phenomenon, where patients and caregivers interpret a lack of symptoms as an absence of disease, in contrast to biomedical conceptions of asthma as a chronic disease requiring maintenance medication even when asymptomatic. These differing perspectives often led to physicians trying to convince caregivers through the use of stethoscopes, spirometry, peak flow meters, or asthma control tests that their child was indeed sick. For example, asthma coach Jeanette from St. Louis primarily highlighted a lack of education and poor health literacy among caregivers as a central issue, and also described frustrations with caregivers who didn't buy into the fact that asthma was a serious condition that needed to be managed. Caregivers' understandings of asthma could lead to dissatisfaction with provider approaches. For example, Melanie, a caregiver from St. Louis, expressed frustration that her pulmonologists really don't say much. She said her doctors, quote, teach you how to use your asthma medication. They go over the asthma study plan. They teach you how to use the inhalers and nebulizers, unquote. But Melanie needed her doctors to address the elusiveness of asthma. Quote, it's just the fact of where did they get this? How did they get this? And there's got to be a better way of keeping it under control, she said. Furthermore, adults involved in children's asthma management may overlook children's contributions to asthma management because we're just not familiar with the steps that children might take to help their asthma. Children's perspectives of asthma could differ quite dramatically from provider understandings. For example, 10-year-old Ashley from St. Louis told us how she used a nebulizer to treat her ragged breathing from crying after her fingers were slammed in a door. In the next few slides, I will demonstrate the ways that caregivers and children understood and treated asthma that can be overlooked, but remain really critical for a complete understanding of asthma management. And we hope that by presenting on these understandings of asthma, providers will be better able to educate caregivers and children on various facets of asthma, as well as establish training for other providers who care for asthma. And with that goal in mind, I will expand on the factors that we found influenced caregivers specifically in the way that they responded to their child's asthma. So caregiver interviews really stress the importance of understanding asthma care in the context of issues like residential segregation, poverty, air pollution, and governmental disinvestment in communities of color. And these issues influenced asthma risk, access to care, and families' living situations. They also led to housing conditions, family structures, and health disparities that shaped how families managed asthma at home. So one thing that was really important was that many caregivers and their families lived in housing conditions that made asthma worse. Events like house fires caused loss of asthma medications or nebulizers and caused trauma and disruption for families. Caregivers who lived in older housing who had landlords who refused to fix problems also struggled with mold, dust, flaking paint, holes in the walls, pests, and other problems. For example, caregiver Tuana moved from her old apartment in Gainesville with mold only to find roaches in her new home. The chemicals she used to kill the roaches also triggered her son Connor's asthma. Tuana concluded, I'm always in a win-lose situation. Tuana's pulmonologist called social services with accusations of medical neglect because Connor was often sick, assuming Tuana wasn't giving him his medication. As a result, Tuana would no longer engage in meaningful conversation with the pulmonologist. As she put it, quote, I talk, but I don't talk, unquote. The pulmonologist's actions, though well-intended, led to a breach of trust between caregiver and provider. And families also cared for asthma across several households, which often made medical care more complicated. Caregivers and their families lived in different houses with different family members. And this made caregivers worried about whether other caregivers would know how to care for their child's asthma. And they also worried when other caregivers held different views and experiences of asthma. For example, Liz described that when her 12-year-old daughter, Courtney, went to her father's house for the weekend, she said they wouldn't make sure she did her inhalers, and they wouldn't make sure she did her Flonase, and they wouldn't make sure she took her Singulair, and she would come back and she'd be struggling. And families also dealt with multiple medical issues in the home at the same time. This meant that asthma was not always a high priority. So most caregivers said that there was at least one other health problem affecting the child with asthma or another household member. These problems included autism, ADHD, complications from premature birth, Crohn's disease, sickle cell, hydrocephaly, COPD, heart disease, dementia, and cancer. Caregivers manage these health issues in the context of other social issues like family violence, incarceration, sexual assault, and caregivers' own physical and mental health issues. These other health and social issues made it really hard for caregivers to prioritize their child's asthma. For example, many caregivers were single parents of multiple children, and some had additional care responsibilities for older family members, while others had personally suffered from illness. Caregiver Nikki described a life revolving around picking up medicine, doctor's appointments for her 5 children, including 10 appointments that week, all requiring travel via public transport and costing about $30 per day. With such challenges to manage day to day, she sometimes forgot to mention asthma when she got to the doctor. And asthma can also be a complex and confusing disease. Caregivers gained an understanding of their child's asthma by comparing their child with other people who had asthma. And these comparisons may be an underappreciated source of information that caregivers use to understand asthma and to make treatment decisions. So comparisons helped caregivers recognize that their child had asthma, help them distinguish asthma from other breathing problems, and to determine the seriousness of their child's asthma. Erin, a mother from Gainesville, said that she could identify an oncoming exacerbation in her daughter, saying, "I can feel it building up, so I know she can too." Tuana, another mother from Gainesville who also had asthma, inferred that her son's asthma was relatively severe because her son needed to use an inhaler daily, whereas she did not. She said, "I can control mine. I don't have to take my asthma pump every day. He has to take his asthma pump every day." Comparisons influenced how caregivers felt about their child's asthma as well. Comparing their child with others who had asthma inspired positive feelings such as gratitude when caregivers concluded that their child's asthma was not as bad as those of others. And caregivers also felt hope when the comparison suggested a possible positive future for their child. The comparisons could also cause caregivers to worry about how bad their child's asthma could become. Kimberly, a mother from Gainesville, repeatedly remarked on how thankful she was that her child's asthma was not as bad as the asthma of other people that she knew. She said, "I know a couple of people that have passed away from having asthma attacks, and I'm just so thankful and prayerful." Such grim comparisons can provide comfort even for caregivers who have children with severe asthma. Caregivers can feel solace that their child is alive. Comparisons also influenced how caregivers manage their child's asthma. Sometimes this resulted in decisions that were different than how doctors and other healthcare providers cared for asthma or could motivate their child's asthma management practices. For example, Kimberly described the daughter of a cousin who takes honey by mouth every day and has no more allergies and no more asthma. She hasn't had asthma in over 5 years. This interpersonal comparison led the caregiver to view honey as a viable treatment for her child. And we also found that doctors understood asthma to be a chronic illness with symptoms that were always present, even if they couldn't be felt. However, caregivers and children use their body to understand asthma as an acute disease with symptoms that were confusing and came on suddenly. Caregivers and children experience asthma at the same time as other sensations happening in their bodies. Asthma symptoms like breathlessness, wheezing, and cough could feel or look very similar to signs of other illnesses. And caregivers often describe challenges with telling asthma symptoms apart from other health issues like anxiety, allergies, obesity, stress, or colds. Children also linked asthma to a range of symptoms, including vomiting, sore throat, nasal congestion, and heart pain. Because asthma symptoms were ambiguous, children and caregivers reported using inhalers to improve breathing difficulties like panic, emotional distress, physical activity, or congestion. For example, Shonda explained, "Sometimes I don't know. Is that your asthma? Is it a cold? Is that allergies?" Mother Rebecca noticed that her son would sometimes use his Saba inhaler but remain breathless. "So you're trying to differentiate, well, how much of that is panic induced and then how much of that is the actual breathing problem," she said. And we also found that severe symptoms of asthma were more noticeable than other features of asthma. People tend to notice changes in their body when they're different from what they think is normal. As a result, caregivers and children often did not notice the chronic airway inflammation that doctors associated with asthma. Instead, they noticed acute symptoms like suddenly having serious trouble breathing. Indeed, severe symptoms or asthma attacks were the most notable part of asthma for both caregiver and children. For example, James, age 12, described an exacerbation that occurred on the bus that previous year, remembering where he was sitting and how the air felt. While Becca, age 10, described her exacerbations as so scary, I thought I was dying. She also said that most of the days, pretty much all the time, it's fine, and that it's more of just a normal me. And asthma was also both physical and emotional. Emotions such as fear, excitement, anxiety, and panic could feel very similar to asthma symptoms of breathlessness. And this similarity made it difficult to determine whether breathlessness was caused by emotions or by asthma. Many caregivers described emotions as triggers for asthma, while others described how feelings of breathlessness from asthma could cause the anxiety or panic. The connections between emotions and asthma meant that caring for asthma often involved caring for emotions as well. Liz, a mother from Gainesville, described that when her daughter Courtney hyperventilated from crying or felt the physiological effects of nervousness, her panic would trigger an asthma exacerbation. She said she has asthma attacks if she gets emotionally upset. Like if she starts crying because she hyperventilates, she could get nervous about something, and then she can realize that it's starting. She feels like her chest is feeling tight, and then she'll start to panic because she feels her chest is getting tight. And the difference between how caregivers and healthcare providers understood asthma may lead to recommendations by healthcare providers that did not match caregivers and children's embodied practices of managing asthma. And now we would like to go into the factors that affect children's asthma management from their perspective. So primarily, while providers in our study mostly viewed children's role in asthma management as related to adherence to medication regimens, children found additional ways to manage asthma. Common self-management activities that children in our study reported doing included detecting and identifying symptoms of asthma, remembering when to bring asthma medications when they left the house, avoiding triggers, and using alternative strategies. Yet these management strategies also face significant challenges. Children develop strategies to manage their asthma in response to the challenges they face in their lives. For children, these challenges included school policies, feelings about medication, and difficulties navigating certain spaces. So school policies shaped children's access to inhalers by prohibiting children from carrying their inhalers with them. School policies also required a school nurse to hold medications. When asked if she had a nurse at school who helped her, 6-year-old Unicorn responded, "They leave at the end of the day. There's nobody going to the nurse." Unicorn's emphasis on the time when the nurse wasn't there indicated her acute awareness of how her access to her inhaler was institutionally mediated. This policy affected younger children more, often because older children were sometimes allowed to carry their medication if they had a doctor's note. However, some children would hide their inhalers in their pockets and use it secretly if they started having breathing problems. Children also felt that their inhalers were important but stressful. Inhalers featured heavily in their drawings and in their interviews, and they recognized how important it was for relieving breathing problems caused by asthma. However, keeping track of their inhaler was challenging and stressful for children because it could be lost, forgotten, or misplaced. Even if children could find their inhaler, it could be empty or expired. Children tried to make it a habit to remember their inhaler so they didn't experience negative consequences of not having one on hand. And children also used water for diagnosing asthma, as well as intervening in symptoms. For children, the advantage of water was that it was highly available. Water fountains were available in a gym class or on the playground, and friends' homes had water. And when a medication ran out, water was available in their homes. Lion Tamer, a child in Gainesville, described, "Sometimes I just drink water, and then I stop breathing deeply." Rick, a child in St. Louis, took 4 bottles with him on a plane to help manage his anxiety, which he considered a cause of his asthma attacks. And so to conclude, we would like to end with a call to recognize diversity in family structures, housing environments with factors outside of caregivers' control, differing protocols for asthma care, as well as various understandings of the nature of asthma as a disease. Recognizing such diversity related to asthma can lead to greater insight into how various groups experience asthma in their day-to-day lives and facilitate improved care that aligns with patients' understanding of asthma. We would like to introduce a few ways that providers can use the information presented in the presentation. And based on our findings, we suggest that providers can acknowledge that caregivers are living in really challenging situations with financial pressures, housing difficulties, complex family situations, and residential segregation. Practitioners could work with social workers to assist with unmet needs, or better resourced primary care clinics could offer advocacy interventions such as medico-legal partnerships with other organizations that aid families in difficult situations. Providers may also proactively seek information about the child's asthma and remain mindful that caregivers may not prioritize non-acute asthma when bringing their child in for other issues. Asking specific questions and continuing to follow guidelines for routine assessment of asthma control may help identify needs that families themselves do not recognize. Providers can also affirm the individuality, ambiguity, and uncertainty of asthma. These conversations can start at or before diagnosis, so caregivers are prepared for uncertainty, and providers can also recognize and explain differences between caregiver or patient experience and the biomedical model of asthma. Providers can also acknowledge caregivers' asthma management practices even when they fall outside of conventional medicine. Providers can ask about caregivers' practices of identifying when their child is having asthma trouble, acknowledge caregiver expertise in their child's asthma, and support caregivers' efforts. This process could increase trust and engage caregivers in the process of creating asthma care plans. Providers can validate children's role and work in their own asthma management by listening and having meaningful interactions with children during clinic visits. Providers can ask children questions like, what are the things you do to manage your asthma? What do those things do for you? And then validate those efforts by saying, you've worked out some good strategies. Would it help to talk through some more strategies to learn more about children's work? And providers can recognize the need to support and educate multiple caregivers. For example, a printed visit summary with detailed asthma care instructions may help communication across multiple households. And ultimately, providers can support further research on children's participation and inclusion in their healthcare. More research on children's experiences of their health and healthcare can support efforts to illustrate how children themselves understand their bodies and their healthcare. Researching on children's experiences can create greater understanding between physicians, caregivers, and other stakeholders about children's roles in their own healthcare. And so next steps for the project include thinking about recruiting providers and caregivers and potentially children with asthma to form a community advisory board to inform future projects on asthma care. And then based off of the feedback from this board, we would like to plan an intervention that targets the needs identified by the community related to asthma care and management. And we're also working on disseminating the results in presentations and publications. And if you would like to learn more or have any questions about the project, you can contact Dr. Waters at her email listed here in the bottom right corner. And here is a list of the published work we used to inform this presentation. And we are currently working on publications related to the quantitative side of the study. You can scan the QR code here by pointing your camera at the square. You don't need to take a picture, you can just point at it. And it will give you a link to Dr. Waters' faculty website with links to our publications. I'll go back to that slide as well. Just want to end by thanking our other team members, as well as the National Heart, Lung, and Blood Institute for the funding to complete this study. And with that, we would love to open the floor for questions and answers if the audience has any questions for Dr. Waters or myself.
All right, that was terrific, Dr. Waters and Sienna, and I really appreciate y'all leaving time for some questions. Folks can feel free to ask questions in the event chat, and I will read them out for y'all to answer. And if I get any questions from other speakers in the speaker chat and Zoom, I will read those out too. And I've seen that we are using the event chat freely to ask Dr. Garcia some questions as well about her presentation, which she has been answering in great detail. While I am waiting for some questions to come in, I'm just going to remind everybody that we've got one more educational presentation today. That's our plenary speaker, Dr. Perpich, who will be going over updates to national guidelines. And then we'll have some other types of content to wrap up the day, like work group updates and some awards for our asthma champions. So you don't want to miss that. But if you do have to step away, you'll be able to watch the recording later. We always like to make sure that we give folks plenty of opportunities to celebrate all the good work that we've done together and all the opportunities that are ahead. Speaking of opportunities, there are CE credit opportunities today. So make sure if you want those CHES credits that you have filled out or are filling out your CHES evaluation form that is linked in the event chat and on the Florida Asthma Coalition website. We also have other types of CE credits available. If you've signed up for other types of CE credit, you will get follow-up from our coalition management team about getting those credits. There'll also be a few questions to answer in your event evaluation survey, which will go out early next week. CE credits for our participants in the Asthma Educator Review mini course will be handled by AAE. So you can follow up with Teresa and Roseanne and any other contacts that they have given you if you have questions about credits for the course that took place yesterday afternoon. I see a comment in the chat. Well done. Thank you for your summaries and ways to address these issues with the full circle of care. Absolutely. Really love the action-oriented recommendations, and those should really be good to reflect on as we listen to our plenary presentation that's up next on the agenda. We've got about 10 more minutes before the national guidelines presentation is scheduled to start. So please do put your questions in the chat to give Sienna and Dr. Waters an opportunity to answer them. And these slides are also available on your agenda to the left of the presentation slide. You can download a PDF of the presentation. All right. Great. And I see folks are also okay with moving ahead a little bit early if we don't have any questions. I do see some feedback from Dr. Weiss saying thank you for a fine presentation. You're just getting lots of thanks. You know, I think y'all really anticipated the questions that people were likely to have by providing some action recommendations. It's a very action-oriented group. So